Hello, and welcome to today's webinar, Report Back from ASCO 2024. Latest updates on metastatic, also known as stage 4 breast cancer. I'm Kate Vieira-Fitzer, the Metastatic Breast Cancer Program Director at SHARE.
And I'm Victoria Goldberg. I'm a host and producer of the podcast, Our MBC Live.
Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone diagnosed with breast, gynecological cancers, and provides outreach to the general public about signs and symptoms. Because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about our upcoming webinars, support groups, and helplines, please visit our website at sharecancersupport.org. We're very excited to have Dr. Kalinsky join us today as a speaker, and now I'd like to hand it over to Dr. Kalinsky to introduce himself.
Hi, everybody. Thank you so much for the invitation. This is a great program. Happy to just be involved. I see a number of familiar names as participants, and it's nice to see you virtually, some of whom it's been some time. I am a breast medical oncologist. I've been at Emory now for about 4 years and came down here to direct the breast cancer program. And then most recently, for the last 102 days, I've been serving as the new division director of medical oncology here at Emory. I'm going to share my slides. Here we go. Hopefully you can see this. Just give me 1 second while I go here. Great. All right, so for the next 35 or so minutes, I'm going to give updates from what we saw at ASCO. And I'm going to talk about at least 2 trials. We will see how we are doing on time. There's a third study that I also included, but again, I may just stop early and take your questions because I want to make sure that we have time to really go through the questions that you may have after the first 2 studies. These are my disclosures. So I'm going to talk about first what I think the most highly anticipated study was at ASCO 2024, and that was the DESTINY-Breast06 study. For those who were in attendance at ASCO, there was a special session that was added to the ASCO event, to the itinerary, so that we could have time to talk about this particular study. So DESTINY-Breast06 is looking at patients with hormone receptor positive, HER2 low or ultra low metastatic breast cancer who had received prior endocrine therapy. So just to give a bit of background, when I was a trainee, and also not all that long ago, we would really think about tumors as being either HER2 positive or HER2 negative. And so if one had a tumor that was, and we score this 1, 0, 2, 3, and if it was 3, it was positive. And if it was 1 or 2, we would do additional testing with oftentimes something that's called FISH. And that would determine whether a patient had HER2 negative or HER2 positive breast cancer. So again, if it was HER2 3+ or if it was FISH positive, it was HER2 positive. If it was anything else, it was considered HER2 negative. But then we saw at ASCO about 2 years ago that for patients who had HER2 1+ or HER2 2+, not amplified, meaning the FISH was negative, we actually now call those HER2 low. And we saw Shanu Modi presented at ASCO 2 years ago that now for patients with metastatic hormone receptor positive HER2 low breast cancer, that we have benefit from giving trastuzumab deruxtecan. That is essentially, it's also called TDXD. and is essentially Herceptin that is linked to a chemotherapy. And again, this is a drug that is approved for HER2 positive and for HER2 low breast cancer. And part of what was being evaluated in the study, so the study was evaluating two things. The first thing was if a breast cancer was HER2 ultra low, meaning it wasn't 0, but there was a little bit of staining, it just hadn't reached the 1+ threshold, was there a benefit of giving the drug? And then the second thing is, what if we gave the drug a little bit sooner? Because right now, we often give the drug after patients have had a line of chemotherapy in the metastatic setting. But the question of this study was, well, what if you gave it earlier? So it's looking at those two things. What about ultra low? And what about if you gave it earlier? So the design of this study, all these patients had hormone receptor positive breast cancer. All of the tumors were either HER2 low, again, that's defined as 1+ or 2+ and FISH negative, or HER2 ultra low. Again, not quite 1+, but with a little bit of staining. None of these patients had chemotherapy in the metastatic setting. All right, so all of these patients had some prior endocrine therapy like anastrozole or letrozole or Faslodex, or i.e. fulvestrant. And a number of these patients also had prior CDK4/6 inhibitors like palbociclib or ribociclib or abemaciclib, okay? So in this study, patients were randomly assigned, had a 50-50 chance to either get T-DXd, which is given once every 3 weeks, versus physician choice chemotherapy. And those options were either capecitabine or paclitaxel, whether that was nab-paclitaxel or general paclitaxel. And the primary endpoint of the study, the thing that they were looking at, was did it take longer for cancer to progress if patients received chemotherapy compared to if they received T-DXd. And so they looked at that HER2 low population, and again, there's a small proportion of patients who had HER2 ultra low disease. So I know that some of these slides have a good amount of information, but I'm going to really try to break it down to the critical piece. So the median age of this study was about 60. All of the patients, for the most part, were women. The percentage of patients was about 20% who had HER2 ultra low disease. So again, the majority of patients had HER2 low, but there was a small proportion who had HER2 ultra low. All of these patients had estrogen receptor positive breast cancer for the most part. There were some, just a few, that had progesterone receptor positive breast cancer. The one thing to know about this study is that few patients had only breast cancer that had spread to the bone. The majority of patients had involvement of visceral organs like liver or like the lungs. So about 2/3 of patients had liver involvement when they participated in this study. In terms of how many prior lines of endocrine treatment patients had had in the metastatic setting, like anastrozole or letrozole or Faslodex or elacestrant, for instance, the median number was 2. About 50% of patients had received only endocrine therapy without another targeted therapy as one of their prior lines. You can see that 90% of patients received prior CDK4/6 inhibitors like abemaciclib or like ribociclib. The other thing that's worth noting is that about 2/3 or so of patients also had endocrine therapy in the early stage setting. So this was the primary endpoint that they were looking at, all right? And so what you're looking at here is what oncologists like to call Kaplan-Meier curves. And what you're looking at in the axis here, I don't think that you can see my cursor, but at the bottom, you're looking at how long were the patients on this therapy in terms of months. And then the top part is just looking at how long was it taking for cancer to progress. And you can see that in blue, those are the patients who had been randomly assigned to TDXD. That the time that it took, the median time that it took for patients to have tumors that had progressed on TDXD was about 13 months. There were some patients that were shorter, some patients that were longer, but this was the median. In terms of physician choice chemotherapy, again, drugs like capecitabine or paclitaxel, that was about 8 months. So there's about a 5-month delta in terms of how long it took for these tumors to progress. And this was statistically significant, right? So the moral of the story of what I'm showing from this slide is that patients that were randomly assigned to TDXD did better than our standard chemotherapy. And what I like to say to patients is the way that TDXD works is like a GPS drug, right? So it's targeting HER2, but the way that your GPS tells you where to go is the way that this drug works. It essentially targets HER2 and then directly delivers chemo to the cancer cell. And what you're looking at here is they also had study radiologists that looked at the time point that it might have seen that these tumors were progressing, and the data looked the same, right? It was a difference of 13 months in those who were randomly assigned to TDXD versus 8 months for those who had standard chemotherapy. So again, those were patients focusing on patients who had HER2 low breast cancer, but there was about 20% of patients who had HER2 ultra low disease. And the results looked very similar, right? Where you saw this delta of difference between those who had randomly assigned to TDXD, it looks the same, 13 months compared to about 8 months for physician choice chemotherapy. And so that's what you're seeing on the left. On the right is looking at survival, right? Did patients live longer if they received the drug? On the left, you're looking how long did it take for the cancer to progress, and on the right, you're looking at overall survival. And the data are immature. They're not enough events to really report this out. We'll see how that trends in the future. But the one thing that I will say, and I just want to give this caveat, is remember that this drug, TDXD, is already approved for HER2 low. And so there will be a cohort of patients who received chemotherapy, and when their tumor had progressed, they could have gotten TDXD as standard of care treatment. And that's going to dilute out the survival data that we see. But again, right now it's immature anyways. TDXD is a drug that we know, but I want to reiterate a few of the side effects that we see. In blue are the side effects that we see from TDXD, and then like the grayish is what we see from physician chemotherapy. So the side effects that we see from TDXD are nausea, vomiting. I have some patients in my practice that they have no issues with nausea and vomiting, and then I have patients that need to come back to get fluids and intravenous anti-nausea medicines in order to support them on this. About 50% of patients lose their hair. Not everybody loses their hair with this drug. The main side effect that it is important that we reiterate to patients is, one, we monitor heart function, every 3 months or so with ultrasounds of the heart. But the other thing that we see is about 10% of patients, there can be inflammation in the lungs. And if it gets to a certain extent where patients are actually coughing or short of breath, some patients need to stop the medicine and may permanently need to stop the medicine. So to reiterate what I showed, patients who had HER2 low breast cancer again, this was at the time that patients were transitioning from endocrine therapy to chemotherapy in the advanced setting. If they received TDXD, there was a difference of about 5 months in terms of the median progression-free survival for those that had TDXD versus physician choice chemotherapy, if it was HER2 low, as well as if it was ultra low disease. And so you can see in blue the take home from this, and that the study helps establish this is an effective treatment option for patients with hormone receptor positive, HER2 negative, HER2 low, and then ultra low disease and metastatic disease in patients who've at least had one prior line of endocrine therapy. These are slides that I'll show from Ian Kropp, who is now at Yale, who discussed this study. And I agree with this take home. So there's some things that I feel like are important to reiterate about this study. So one of the things for patients with hormone receptor positive, HER2 negative or low or ultra low disease, we want to continue endocrine-based treatment with or without targeted therapies like a CDK4/6 inhibitor or like a PI3K inhibitor or like everolimus for as long as we can before we even need to think about chemotherapy, right? And so the data that I showed you now is after patients have received prior endocrine therapy, because this is a marathon, this is not a sprint. And so we want patients to be on well-tolerated therapies, which do not require time in the infusion center for as long as possible. So once a patient has a tumor that is no longer endocrine sensitive, that is when we start thinking about this drug. And I will say, for some patients, when we start thinking about does somebody need chemotherapy or a drug like this, it's still reasonable to think about giving other drugs like capecitabine, which is an oral chemotherapy, to patients, especially patients who have limited disease. It may just involve the bone. It may be that they were on endocrine therapy for a long, long time. It's not inappropriate to think about giving capecitabine for some patients. But if you have a patient whose tumor is rapidly progressing, you may need a little bit more of a response, and you're just concerned about the pace and the cadence of the disease, that's when I think, oh, well, at least now I have TDXD, and I can give it a little bit earlier. So this is a schematic of where things are for metastatic endocrine positive disease, where we give endocrine therapy and a CDK4/6 inhibitor, often frontline. That second line is endocrine therapy with a PI3K inhibitor, or maybe continuing a CDK4/6 inhibitor. And I'll discuss the data supporting that sort of approach in the next study. Or if a patient has an ESR1 mutation, there are data about giving single agent elacestrant. And so, like I had mentioned, you want to continue endocrine-based treatments for as long as you can. But once you've reached the point where it's not responding to endocrine-based treatments, that's when this study comes into context. So if a patient has HER2 low or ultra low disease, it's reasonable to think about trastuzumab deruxtecan. Though for my patients who have a low volume of disease, like I'd mentioned, capecitabine is absolutely reasonable. And then if a patient has truly HER2 zero, HER2 not ultra low, but HER2 zero disease, then giving something like chemotherapy and then giving something like sacituzumab, which is a different antibody-drug conjugate, is entirely appropriate. The other thing that I will just mention is when I was sitting in the audience and I was listening to the data from the speakers, is I was texting my pathologist just saying, well, what are we going to do? Because at all of our institutions, we don't actually report ultra low. We report it as HER2 0, 1, 2, 3, positive, low, but we haven't been describing it as ultra low. So you may see at your specific institution that we're starting to evolve where, once we have NCCN guidelines that include ultra low, that we may be actually reporting this out. And each institution may report it a little bit differently. But at Emory, where I am right now, we've already started to make that move so that we can try to get approval for patients who may have ultra low disease that would benefit from getting TDXD. All right. I look forward to any questions that people have about that study. And then I'm going to spend some time talking about PostMONARCH. And then depending upon where we are with time, I may actually stop and then see what questions everybody has, because there's a good amount to talk about with this study as well. So this was a study that I was fortunate to present at ASCO, which is called the PostMONARCH study. So this study is, again, we're talking hormone receptor positive, HER2 negative disease, though when I say negative, I mean anything but positive, right? So this could have been HER2 0, 1+, 2+, just not positive, okay? And so as a little bit of background, and I've already kind of been alluding to hormone receptor positive metastatic disease, we've had some advances recently where we base decisions after a CDK4/6 inhibitor, right? So if you have received endocrine therapy plus a CDK4/6 inhibitor like palbociclib, ribociclib, or abemaciclib, there are drugs now that are approved based upon the next generation sequencing that has been done either in blood or on tumor tissue. So for instance, if a patient has a PI3K or AKT mutation, we have the approval of alpelisib. We also have the approval of capivasertib, and that's given often in combination with fulvestrant. For patients who have an ESR1 mutation, we have giving single agent elacestrant right now. And you can see in this schematic, the median progression-free survival, 0, 2, 4, 6 months. These are the data from the studies in the biomarker positive population after a CDK4/6 inhibitor. So in blue, these are the patients that got fulvestrant plus alpelisib, where you can see that the median time that they were on that combination was a little shy of 6 months, same for capivasertib and fulvestrant, but that is compared to less than 2 months with single agent fulvestrant, which is why we've moved away from giving single agent fulvestrant to patients. And with elacestrant, the median progression-free survival in the overall population for those with ESR1 mutations was about 4 months. And so you can see that while we have made some advances, we are looking for additional treatments to help support our patients after progression on a CDK4/6 inhibitor and endocrine therapy. And also, you can see the discontinuation rates that are observed in these trials, where, for alpelisib, for instance, about a quarter of patients had to stop the drug due to intolerance of the drug. So this is the design of PostMONARCH. And I will also say we've seen studies of giving, if you've had endocrine therapy and a CDK4/6 inhibitor and the tumor has progressed, where you're randomized to switching the endocrine therapy with or without a CDK4/6 inhibitor. We've seen some different results, and these have all been phase 2 studies of about 100 or so patients. This is the first global phase 3 randomized trial that is answering this specific question. So in this study, all patients had hormone receptor positive, HER2 negative breast cancer. This is a true second-line study, meaning that there were no other treatments that were given in the metastatic setting after the tumor had progressed. So none of these patients had chemotherapy in the advanced setting. Patients went directly from that CDK4/6 inhibitor endocrine therapy to receiving fulvestrant with or without abemaciclib, okay? And again, we were looking at how long did it take the cancer to progress. So there's some things that I want to point out. 2/3 of patients had cancer that was involved outside of the bone. 40% had disease in the liver. Around 20% had disease in the bone only. Almost all patients had received that prior CDK4/6 inhibitor in the metastatic setting. During the lifeline of this study, abemaciclib was approved in the early stage setting, but it was less than a handful of patients. that met those criteria. 60% of patients had prior palbociclib, a third had prior ribociclib, and 8% had prior abemaciclib. A quarter of the patients were on that prior CDK4/6 inhibitor for less than 12 months. The vast majority were on their prior CDK4/6 inhibitor for greater than a year. And the only other thing that I wanted to point out is if you look at those who are on prior palbociclib or ribociclib, in blue are the patients who are randomly assigned to the placebo arm, and in red are the patients randomly assigned to the abemaciclib arm. Numerically speaking, patients were on their prior palbociclib and ribociclib a little bit longer in the placebo arm compared to those that were randomly assigned to abemaciclib. So we talked about the Kaplan-Meier curve, and these are the data that we have from the study. So you can see that the median time that patients were on abemaciclib plus fulvestrant, again, this is after a CDK4/6 inhibitor, was about 6 months. In the fulvestrant alone arm, it was about 5 months. And this is the best that we have seen single agent fulvestrant do. There are a number of hypotheses of why this could be. None of these patients had prior chemotherapy. In all of the other studies, they allowed prior chemotherapy in the advanced setting. Also, keep in mind that this study was going on at a time that we were seeing how patients with single agent fulvestrant were doing. And so we could have absolutely been biased in terms of the patients that we would have thought about putting onto this trial because of the concern that patients would have received single agent fulvestrant. So in other studies, the median time that patients are on single agent fulvestrant is probably about 4.5 months. In other studies, it's been about 2.5 months. So moral of the story is the placebo arm here did better than how we've seen in any of the other studies post-CDK4/6 inhibition. But at the end of the day, there was still a 27% reduction in developing progression if patients were randomly assigned to abemaciclib. So I know that there's a lot that is on this slide, though it is an important slide. So we looked at different subgroups of patients and looked to see, okay, were there some patients who seemed to benefit more from being in the fulvestrant alone arm than those who were randomly assigned to abemaciclib plus fulvestrant? So here, this is the abemaciclib arm, to the left, and to the right is the placebo arm. And you can see all patients pretty much seem to benefit from the addition of abemaciclib. Whether one had disease that was measurable, whether one had disease that was in the liver, we saw that the benefits seemed to be about the same no matter how long patients were on their prior CDK4/6 inhibitor. The one real bit of conversation / controversy that happened during the question and answer session during this presentation is that look at the bottom of the slide in terms of prior CDK4/6 inhibition. You can see that the hazard ratio, that curve, where the red dot is, that patients seem to do better getting abemaciclib if they had prior palbociclib. That benefit didn't seem to be quite the same if they had prior ribociclib. And there was a lot of controversy about this, asking the question, is the benefit here really being driven by prior palbociclib or not? But I just caution in terms of overinterpretation of these data because, almost 2/3 of patients had prior palbociclib. The ribociclib group, relatively speaking, was small, and we'll see how this translates into future studies. It's too early to say whether this benefit is really limited to those who had prior palbociclib, because you can also see that red dot for those who had prior abemaciclib was about the same as what we saw with prior palbociclib. So I'm showing you some additional Kaplan-Meier curves. where you're looking at, well, how long was the patient on their prior CDK4/6 inhibitor? Less than 12 months or greater than equal to 12 months. And you can see that both groups seemed to benefit. There was a difference in both groups. And those who were less than 12 months, the median time that patients were on the drug was about 2.5 months longer if they were randomly assigned to abemaciclib, and about 1.5 months if they were on their prior CDK4/6 inhibitor for greater than or equal to a year. And then the other thing that you're seeing here is whether patients pretty much had bone-only disease or not. And if patients did have bone-only disease, there was about a 5 to 6 month benefit for those who were randomly assigned to abemaciclib, where you see the median progression-free survival difference of 11 versus 5.5 months. And if patients had visceral metastasis, right, so disease in the liver or the lung, that there was a benefit of about 2 months or so if patients were randomly assigned to abemaciclib. One other thing that we looked at, because I already talked about whether, if you have a PI3K or AKT mutation, there's the benefit of giving capivasertib. If patients have an ESR1 mutation, those are the patients that benefit from getting elacestrant. So we looked at circulating tumor DNA. We looked at this in about 85% of patients. And what we saw was that regardless of whether a patient has an ESR1 mutation or a PI3K mutation, that there's benefit for getting abemaciclib. And we will be reporting at upcoming congresses additional data looking at different mutations. The safety that we see from and toxicity that we see from abemaciclib is well known. The main side effects we see are gastrointestinal issues like diarrhea, and about 6% of patients needed to discontinue the drug due to toxicity. So the moral of this story from this study, and then the next few slides, I'm just going to contextualize this, and then I actually may stop because I want to make sure that we have time to talk through any questions and clarifications that we need from the two studies, because these were really the two studies that I think caused the greatest amount of discussion at ASCO. So this was the first randomized control trial that looked at patients continuing a CDK4/6 inhibitor and switching the endocrine therapy after their tumors had progressed on endocrine therapy and a CDK4/6 inhibitor. And we saw an improvement in how long it took for breast cancer to progress. And we already talked about the rates of discontinuing the drug, and that the toxicities are what we would have anticipated, primarily gastrointestinal issues. And so there seems to be a benefit of abemaciclib and fulvestrant, regardless, not selected for biomarker status, because I showed you the data that we saw this benefit regardless of patients who had an ESR1 mutation or PI3K mutation. So the take home from this study is that the addition of abemaciclib to fulvestrant improved progression-free survival in patients who received a CDK4/6 inhibitor in the first line. The patients who were on their prior CDK4/6 inhibitor for more than a year, and those who had primarily bone-only disease, were the ones who had the longest progression-free survival. And so this is a potential option for patients, especially in patients who do not have a targetable mutation. So this was a slide that my colleague, Dr. Ruth O'Regan, who discussed the data, which she presented, and I'm just going to spend some time going through this, and then I'm happy to open this up and answer questions that may exist. So patients, for the most part, are receiving endocrine therapy and a CDK4/6 inhibitor frontline. At least that's how things are at the moment. If a patient does next generation sequencing at that time, and we're testing for an ESR1 mutation or a PI3K/AKT mutation, if there are no mutations that are seen, which in PostMONARCH was about 30% of the patients who are randomly assigned, we have options. The option is to either switch the endocrine therapy and switch the CDK4/6 inhibitor, You can switch the endocrine therapy and use something like everolimus. But if you have a patient who has a tumor that's rapidly progressing and you're just concerned that they're no longer endocrine sensitive, that's where chemotherapy may come in. That's where trastuzumab deruxtecan, the study we just talked about, may come in. That's where sacituzumab govitecan may come in. So that's where, other non-endocrine therapies may come in. So just to take a step back, if you have a patient who received endocrine therapy and a CDK4/6 inhibitor and they have an actionable mutation, if they have a PI3K mutation, then you may think about giving them either capivasertib or alpelisib, though I will say increasingly we're giving patients capivasertib because it's easier to tolerate than alpelisib. If patients have an AKT mutation, then capivasertib is approved. If a patient has an ESR1 mutation, then you may think about giving elacestrant. And then if patients have a tumor that have progressed on those, then you can go back and you can maybe give a CDK4/6 inhibitor endocrine therapy, or maybe you can give everolimus at that time. It really depends on the patient and what's going on in their disease at that time. The only other thing that I will say, and then I will pause and I look forward to any questions that you may have, is that we know that capivasertib and alpelisib are not tolerated in all patients. As I mentioned at ASCO during the question and answer session, I practice in Georgia. Not everybody has uncontrolled diabetes. And one of the side effects, the major side effect that we can see from capivasertib and alpelisib, can be an increase in blood sugar. And you actually, to go on these studies, had to have very strict criteria for your blood sugar control. And so if I had a patient in clinic who had a tumor that had progressed on endocrine therapy and a CDK4/6 inhibitor and has a PI3K mutation, but has an uncontrolled diabetic situation, I still may think about doing the data that we saw from PostMONARCH of giving fulvestrant plus abemaciclib, because I may be concerned about their tolerability of taking capivasertib and alpelisib. So at the end of the day, to me, this is just adding one additional strategy for our patients. And the other thing that I will say, and I will pause for the questions that you may have, is that this is a moment in time. Like, this is where we are right now in 2024. But the field is rapidly progressing. There are a number of new endocrine therapies that we will see read out from phase 3 trials in the next year. There are new CDK-specific inhibitors. There are new specific PI3K inhibitors. There are other drugs that are optimizing our the benefit that we see from endocrine therapy. So this is where things are today, but the field continues to rapidly progress in a good way, meaning, we already see CDK4/6 inhibitors have changed the landscape of how we treat patients. Elacestrant and capivasertib have been new additions to our armamentarium, and there's no reason to think that that won't be the case for other studies that we'll be reading out for our patients as well. So I want to thank you for your attention. I'm going to stop sharing my screen, and I look forward to questions that you may have.
Thank you so much, Dr. Kalinsky, for that presentation on those two studies. It was a lot of information, so I appreciate you stopping and having some time for some questions that specifically are focused on those two studies. So we have a question, and they really like to take a step back and talk about the IHC testing and versus FISH testing. And should patients be asking to be sure that both tests are done?
Yeah. So I will even take a further step back. When the HER2 test was being designed, it was really meant to be designed to distinguish positive versus negative. And now we are putting increased emphasis on a marker, on a test that is being used in a way that it really wasn't initially designed, right? It was really designed to just test positive versus negative. And so, the marker itself can change over time. And so there are a few points that I want to make. So one, if a patient has a tumor that is HER2 0 at the time of metastatic diagnosis, it is reasonable to rebiopsy again in the future, because there were some data, including data that were presented at ASCO last year by the Mass General group, that the more biopsies you do, the more likely you're going to find something that's low. So that's point number one. And then, point number two is just that our drugs are getting better. And, there's what we call the bystander effect, where even if there's just like a little bit of HER2 that's there, we're able to get much more bang for our buck with drugs that are more active, because it's, impacting the local surrounding cells. And so, those are the points that I would make. But I also do think that it's important that we still, if you have a tumor that's HER2 1+ or 2+, it is still absolutely standard of care to make sure that it's not FISH positive, because that can happen.
So you talked about rebiopsy as you go on. Have you ever seen the case where someone may be positive and then they're like 1+, and then upon progression, maybe years later, they actually change to 0? Could that come up? Is that a problem? Because what we see with that data, you're talking about ultra low and 0.
Yeah. I think we're starting to understand this. The other thing to be clear is, you have one may have different areas of cancer, and we're only going in and biopsying one area versus another, right? So sometimes it's just based upon where you're sampling. The Duke and Dana-Farber group presented some data at San Antonio this past December, where they looked at that question. Okay, well, if you had a HER2 2+, and then it was HER2 0, and then at that point you got trastuzumab deruxtecan, the take-home point from their data was that the benefit from the drug seemed to be most dependent on what the last biopsy showed.
Oh, okay.
So those are the data that we have now, but that was from, a relatively small series of patients.
Dr. Kalinsky, I have a question that probably a lot of the audience is thinking. So I'm going to voice what everybody else is thinking. So we're listening to all of this different ways of figuring out if you're HER2 low, HER2 ultra low, HER2 negative. But in reality, every person has HER2, right? It's not something that there is maybe very little, but every cell has a little bit of HER2. So is there any reason at all, and I'm sure there is, and you'll explain why, we need to test for it at all? Because, Trodelvy is TROP2 target, and nobody tests for TROP2. So what is the point of going into all these detailed analysis of HER2?
Of those patients of HER2 negative breast cancer, 85% of those have HER2 low or ultra low. There's a small proportion of patients who remain HER2 0, like 0, 0, 0.
0, 0.
So, but you're asking a good question, and one that we ask. I mean, I've asked also, of like, does it even matter, right? Can you just give the drug?
Right.
And we may end up getting to that point, because we are a bit in a predicament now where we don't really report out HER2 ultra low. And so now we're in a point where we have to convince payers to cover it and convince our pathologists to check it in, in the first place. And so, as our drugs get better, I do think that remains an important question for an imprecise marker.
Thank you. That's good to know. So I want to ask you one more question related to HER2. And that is something that you actually had spoken about, the ILD, this rare condition that's very, very dangerous. And it's evaluated by grade 1, grade 2, and higher. So can you talk a little bit about when you would stop the treatment when ILD is 1, or would you stop at 2? Would you ever go back if a person has grade 2 or greater ILD?
Yeah. So when the drug was first developed in the first early phase study, there were patients that died because of the pneumonitis, right? Because of the inflammation in the lungs. So even from its first presentation at ASCO now several years ago, that was the biggest concern in terms of the toxicity. So the way that the prescribing information defines what we should do is if one has grade 1, which is asymptomatic, and you just see it on the scans, then you should hold, you should give steroids, see that it gets better, and then you can resume. If it's grade 2 or higher, meaning that patients have symptoms like cough, shortness of breath, one's supposed to give immunosuppression like steroids and then not re-challenge. That's the book answer. And it's hard. This is hard. And I mean, I have a slew of patients who I have 2 patients in particular right now in my practice, like as of this week where this was an issue, one of whom is having a tremendous response to trastuzumab deruxtecan and probably has grade 2 pneumonitis, but also has disease where we need to do something. And so it's quite a clinical quandary. The book answer to your question is at grade 2 or higher, we should not be continuing. Grade 1 or lower, like once it resolves, grade 1, if it resolves, you can re-challenge. That's the book answer.
Thank you very much, Kate.
Yeah, so the next question I have is, you talked a little about Trodelvy, and so we have these 2 antibody drugs, Trodelvy and Enhertu, and they're approved already in the metastatic population. And then we're seeing some positive results with the Dato-DXd, another antibody drug conjugate. And I'm thinking about asking your thoughts about sequencing of these drugs. If someone progresses on one, are they likely to benefit from the other as well, because they are similar but yet different? Can I have your thoughts on that?
Yeah. So the data that we saw at San Antonio last year were that the first antibody drug conjugate seems to be the one that patients benefit from the most. Not always, but really most of the time. And that has been anecdotally what I have seen as well. Part of our issue at the moment in clinic is that while the target may be different, right? One's targeting HER2, and then the other 2 drugs that you just mentioned, Trodelvy and Dato-DXd, which isn't approved yet, but we hope will come to the market soon.
Right.
Both target TROP2. But the issue is that the chemo that they are linked to has the same mechanism of action. They're all topoisomerase inhibitors. And so we are in need of newer targets with newer payloads, right? Newer chemotherapies that they're linked to. And there's some that are like very much in development, but that's part of the clinical quandary that we're in right now. And so to answer your question, I do sequence the ADCs. And the other question that they looked at is, does it matter if you go directly from one ADC to another? Or if you give something in between, they'll give a bit of a washout. Does it seem to be better? Doesn't seem to have any difference. And so I often do back-to-back ADCs, but in general, the first ADC is better in its efficacy.
Thank you.
I was gonna go over to the next study, and I have to tell you, I was completely blown away by some data, and I want to ask you. But before I go to that, there is a question here live, and I think it's worth getting an answer. I think there is some confusion. So we're talking about hormone positive people who start their treatments in the metastatic setting with endocrine treatment. Once you become resistant to endocrine treatments, you start talking about later lines of treatment, right? You start talking about chemo, Enhertu, and by the way, that was a very interesting slide where you showed what to do for people, either go to chemo or go to Enhertu or Trodelvy. But there's a question here. Do we still need to stay on endocrine treatments once we go to HER2? There seems to be some thinking that we might.
Yeah. So for patients who have estrogen receptor positive, HER2 low positive disease, ultra low, whatever the case may be, in the metastatic setting, I often do not continue endocrine-based treatments. And the studies in HER2 had a nice response, right? We see really good shrinkage. And so I don't generally we don't generally think of the additional endocrine therapy as adding much, besides possibly toxicities. And so often when we're giving the antibody drug conjugate in the metastatic setting, it is often giving them alone.
Thank you. Thank you very much. Do you want to go to the next?
Yeah, so we have another question that's really important, and I think we should target this one. So in progression, does it matter if you do a liquid biopsy or a needle biopsy?
So liquid biopsies are easier for us to obtain, right? And
Right.
so when we are looking at the question of, oh, is something HER2 positive or HER2 low or ultra low, that has to be done on the tumor, right? That's not done on a liquid biopsy. That's done on tumor tissue. And so if that's the question that you're looking for, you have to do a biopsy of a metastatic site. Commonly, we are doing, outside of that, a liquid biopsy. And then if that doesn't show anything, that's when I may do a biopsy to then do sequencing on the tumor. It may be, especially for these estrogen receptor positive breast tumors that have low volume of disease, have a low pace of disease, those are not shedding cells into the circulation much. And so that's the time that I reflex back and then do testing in the tumor.
Thank you.
Thank you.
All right, so I'm gonna go to PostMONARCH because I'm really excited about that one. So one thing that completely blew me away was the slide where you showed the difference of progression-free survival for, was it progression-free survival? Overall survival, I think, for a group on on Abema with visceral metastasis versus the placebo control group. And the difference was just, I guess, a month or so. So the question I have, and probably people do too, is it worth it in some cases to go into all this additional, and we know that abemaciclib is not an easy drug. There are a lot of side effects. Is it worth adding abema to the regimen?
Yeah, so we were looking at, you're right, it was progression-free survival. And there was a difference of about 2.5 months in those who had visceral metastasis, about 2 months, it was about 2 months between those who had visceral metastasis and received fulvestrant versus fulvestrant plus abemaciclib. So I will say in other studies too, whether it's the Capitello 291 that led to the approval of capivasertib, or Solar One, which led to the approval of alpelisib, visceral metastasis can be a more concerning feature. And so the data that we showed here is consistent with what we've seen with the other studies. And I would just keep in mind that this is the median, right? This is the median time. There's some patients that are shorter, there's some patients that are longer. And so I think that those are patients in particular that we may have concern about the volume of their disease, that I think is really the population who will most benefits from combo therapy, but saying that the combo therapy that we're giving now could be better, right? So that's the point that I was also trying to make in terms of where things are in 2024, is like, these are the drugs that we have right now. We know the areas that we need to make improvement. And so this, to me, this is laying the, like, overall, in PostMONARCH, even for all the patients who are getting abemaciclib plus fulvestrant, I think we can all agree we want better than 6 months median progression-free survival. Like, we all want that, right? And so this is laying the groundwork for other studies and the benchmark that we're trying to surpass. And I'm hopeful with new drugs that are being tested that we could reach that.
Okay, and I'll ask Kate, I'll ask a very quick follow-up question because I think it's important also to mention that you noted it in the presentation that we talk a lot about now primary and secondary resistance, and primary resistance is a high-risk group that progresses either while on adjuvant therapy or soon after. So we're not going to talk about inavolisib, which is another new drug that's quite promising. But you did mention in this trial, in the PostMONARCH study, there was a group that was tracked, and that's that high-risk group. So in your opinion, and did the trial show, is it worth it for that group once they progress on the first CDK4, go to the next one?
Yeah, for those patients who were on for less than a year, it was the minority of patients that was the case. It was about 25% or so. They still seem to benefit, in terms of the hazard ratio similarly. And those are patients that, even if you look at elacestrant, for patients who have ESR1 mutations, don't seem to really benefit that much from elacestrant. And so those are the patients that I even feel more strongly about giving a combo of drugs, understanding that I want that combo in the future to have greater activity.
Thank you. Hey.
So I think we're running almost to the end. I think we're going to ask one quick question. I'm so sorry if we didn't get to your question. We have so many that we would love to answer. So we have a question. You had showed the sequence of treatment upon progression and looking at mutations. And we have a question regarding anything maybe new in the pipeline to replace the fulvestrant shot, or have you heard of any of the oral SERDs, and what does that look like? We know that there's a lot in clinical trials.
Yeah, I'm going to point out 2 trials, one that's enrolling and one that's completed enrollment to have your eyes on. So the study that is currently enrolling is a study that's called the ELAINE study, ELAINE-3 study, where patients have tumors that progressed on endocrine therapy CDK4/6. They have an ESR1 mutation, and they're randomly assigned to fulvestrant plus abemaciclib, right, the PostMONARCH combo, versus lasofoxifene, which is a new oral SERM, selective estrogen receptor modulator, plus abemaciclib. So that's an ongoing study. And then the study that's been completed is EMBER-3. So EMBER-3 is a study of about 800 or so patients, same kind of population, where they're randomly assigned to the oral SERD imlunestrant plus versus physician choice endocrine therapy like fulvestrant versus imlunestrant plus abemaciclib. And it's that third arm that is going to be the most interesting of the arms, because the question is going to be, well, how does that compare? Of course, we don't want to do cross-trial comparison, but what does that look like with that combo compared to what we saw with fulvestrant plus abemaciclib?
Okay, so we're completely out of time. No time to ask one more quick question. Oh, Dr. Kalinsky, we will have to have you back because we did not talk about triple negative. We did not talk about HER2 positive. I mean, there is so much stuff still to go over, so you'll need to come back.
That sounds good.
Thank you so much.
Please make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. This concludes the webinar. Thank you so much for coming. Bye.